Good evening, everyone. My name is Dr. Ansel Johnson, and I am the CEO and founder of Healthy Living with a Vision Foundation. And I want to welcome everyone to our town hall meeting on low vision and vision impairment. And I am so excited that we have some special guests with us tonight. And I want to welcome all of our visitors. But first, let me tell everyone about our foundation, as we have been sponsoring these activities for over a year and a half now. Healthy Living with a Vision Foundation is a 501c3 not-for-profit organization. And our mission statement is to eliminate healthcare disparities in communities of color. And low vision is just one of the initiatives that we have. But let me tell you about some of the other things that we have done. We started off with the idea of providing funding for people living with diabetes and diabetes education, because studies have shown that people living with diabetes and having an educator and going through sessions, learning about how to live their lifestyle, have been shown to lower their A1C and have less complications from diabetes, which one of the major ones is blindness. So when we tell our patients that they have diabetes, and we have to let them know that it is one of the leading causes of adult blindness, diabetes. So I've always been interested in patient education. And when I was finding that patients were not getting diabetes education in our office, and for various reasons, could be lack of insurance coverage, lack of knowledge, lack of having that referral, I had said, well, what can I do? And so what we did, we jumped through a few hoops and we got some things going and get our program nationally certified. So we are the only eye care facility in the state of Illinois, and only one of 3 in the whole United States that have a certified diabetes education program. So most of those programs are affiliated with large clinics and hospital limited hours, where what we do, we're able to pivot a little bit and provide services over Zoom and in person. And so the other part of that, with our foundation, we are raising money so people can have it regardless of their insurance coverage. They can get free diabetes education and free supplies. Our next initiative, because what's hot in the area of diabetes is continuous glucose monitors, which are expensive. And again, insurance coverage issues, but have been shown evidence-based to really help people control their diabetes. That's one initiative. Pandemic hit. We were originated in Juneteenth, 2020. And so what happened? Pandemic. So we had to pivot. And we pivoted and were one of the first not-for-profits to have town hall meetings about COVID. And at that time, there were no vaccines. The problem was testing. People were looking for a place where they could be tested for COVID-19. So we pivoted. We had town hall meetings. We were overwhelmed with the interest. It kind of blew up our whole Zoom program. And we were able to do that. We've done about 5 in the series. So our medical director is the expert on that. Another one of our board members is a kidney transplant recipient, high energy nutritionist, but she's also a Whitney Houston impersonator. So she is looking for a new kidney. So we've done some things with kidney health awareness and organ transplantation, donor volunteers in communities of color. So that's another initiative that we've done. And we've done in-person panels at churches, and we are about to partner with one of the hospitals in the Chicago area to actually get out in the community more and just have some healthcare panels where we have experts, so people can ask questions that they might not have thought of in their doctor's office or didn't know to ask. And we can educate them and help empower the public to take control of their healthcare. One of the buzzwords in healthcare nowadays is patient-centered. So we have to look and meet the patients where they are and guide them to help engage them in their own healthcare. And optometry, in my heart of hearts, is really key to doing that, because what do we do better than most other healthcare professions? And let's talk to our patients. So those are just some of the things that we're doing as a foundation. Healthy Living with a Vision.org is where you should check out our website. And please, if you've gotten anything from this, just give us a few dollars or more if you want, as much as you want, to help us expand these initiatives. Another initiative here, circling back to our low vision awareness, I have to confess, I'm a self-proclaimed under low vision referrer. And our office is mostly ocular disease. And there's so many times we as general optometrists or medically oriented optometrists or contact lens specialist or pediatric optometrist, when we have a patient and we just can't help them anymore with conventional lenses, and we don't think often enough about, you need to see someone that can really help enhance your life, improve your life, even though you don't see 20/20 anymore, but can help you move through this world a lot more effectively. And so this is a passionate area of mine with low vision. And so I'm not a low vision expert. I'm not a low vision specialist, but I do definitely refer a lot more than I used to. And I know and we in optometry in general do not really refer enough. So this whole panel discussion, we have a special theme here. And also, let me back up a little bit, give you my background. I've been in practice since a while. Since 1990, I've been in private practice. As I mentioned, ocular disease is a big area of mine where we see a lot of patients living with diabetes and glaucoma. And we have a lot of high technology in our practice. I've been very active in the community for, again, over 32 years now. I am blessed to be joined by some very special people on this panel. The theme for this particular program, it is Black History Month, it's Low Vision Awareness Month, and it is also Age-Related Macular Degeneration Awareness Month. So we have a few things. So what we're doing, we're really highlighting some African-American experts and advocates in the field of low vision. Now, two of our panel members could not join us today, but I do want to mention them too. Real quickly. One is Parise Wright, who runs the low vision clinic at Chicago College of Optometry from Midwestern University in Downers Grove, Illinois. And the other person, our low vision advocate, is Janet Lebrecht, who again is under the weather and could not join us. But Janet Lebrecht, to give you a little bit of background of her, she worked in the Barack Obama administration and was actually conferred by the US Congress to serve as Commissioner of Rehabilitative Services in the Department of Education. So we're gonna miss her, but she will be on our next one, God willing. And is again, Parise Wright, who could not be with us. But we do have Dr. Susan Primo, who I'm blessed to have as a classmate from the New England College of Optometry. She might not feel the same way about me being her classmate, but I'm glad to have Susan, Dr. Primo, excuse me, on the line right now. And let me tell you, as one of the very leading thought leaders in the area of low vision in the United States, she is professor of ophthalmology and director of optometry and low vision services at Emory Eye Center in Atlanta. And as I mentioned, she is my classmate from the New England College of Optometry. And she believes that strategic public health approaches to address vision impairment and vision loss are desperately needed. She also received her master's in public health degree in 2002, and in the hopes of being in a position to help combat this problem. And again, she specializes in low vision rehabilitation with patients. that are visually impaired. She's actively involved in vision rehabilitation research, including low vision outcome studies in collaboration with Johns Hopkins University, age-related macular degeneration, and cortical reorganization in collaboration with Georgia Tech and the implantable miniature telescope clinical trials. I also have on this panel a guest, and I'll let her introduce herself to you in a little bit, but that is Dr. Samantha McIntosh, and she is Director of Low Vision Services at Nova Southwestern School of Optometry in Florida. And then I also we'll introduce a little bit more later on our very special guest, Dr. Keisha Elder, who is the first African-American woman Dean of Students at a School of Optometry in the whole United States. So she's special, y'all. And we'll get to Dr. Elder a little bit later. And right now, like I said, the first part of this presentation is all about low vision. And what we want, those of us that are in the healthcare profession, we just want to raise our awareness about the importance of making that referral for low vision, but also people that are consumers that don't know anything about vision impairment and don't know how difficult and how special people that have vision impairment must move through their world, and how when you have the diagnosis of legal blindness does not mean you cannot see anything, or does not mean that your world is black, but that you can be very functional in so many different ways. So with all of that said, I'm going to get started with Dr. Primo, and anything that I missed about your illustrious background, please fill everyone in. But Dr. Susan Primo.
Well, the first thing I want to say is you said that you have been in practice 32 years, and so we graduate together. So the number is actually 38 years, so I'm not going to call you that. So we're a little older than you're trying to make yourself out to be. Yes. But anyway, I have had the fortune of being a vision rehabilitative specialist. And let me first say, for some of you on the Zoom today, we're trying to move away a little bit from the term low vision to vision rehabilitation, because it can often be confusing. What does low vision mean? And there's a spectrum, right? There's very mild low vision, and then there's very profound low vision, including blindness. And so we're trying to move away from just that term to really make it more encompassing, to call it vision rehabilitation. And the reason for that is because it's not just something that I do or Dr. McIntosh does. It's something that is a rehabilitative process. And the underlying theme of that is improving quality of life. And what that means is that if you have a vision impairment, whether it's mild or severe or blind, that there are tools, there are all sorts of technologies, there are all sorts of things that one can do to have a full quality of life. And so just like if you were to, sometimes I use the analogy with my patients, if you break your leg or your arm, you've got the orthopedist that sets the cast, then once the cast comes off, then you go to rehab sometimes because now your leg or arm doesn't work like it used to. And so now you have to get it back to full strength. And then sometimes that takes another few weeks. Well, the same sort of concept is with the eye, and when vision loss occurs, it has to be rehabilitated. And so you have to figure out some of the things that you can do, even though if it's a problem that can't be cured or treated. That's where I sort of step in, and Dr. McIntosh, we step in to try to take the remaining vision that a person has, whether like I said, mild or profound, and try to figure out what tools, what training, what resources, the whole gamut of what we can do to help rehabilitate you so that you can have a full quality of life. And so that's, I think, most important. So, I got my passion for vision rehab back in optometry school. I did a rotation at the VA in Eastern Blind Rehab Center in West Haven, Connecticut. And it was a fantastic experience. And honestly, I didn't know a lot about this field when I was in school. There's not a big teaching, and hopefully Dr. Elder can talk about this a little later, but there's not a huge educational program around, or Dr. Caruso, around teaching vision rehab services or what it is. So I didn't know a lot about it. And so I took this rotation, honestly, just to get out of Boston for 3 months. That was my excuse. But then when I got there, it was just an amazing experience, and how I could help somebody. First of all, I was seeing all these eye diseases that were just rare and these fantastic veterans that were there that were trying to improve their quality of life. And so I was able to really start from the beginning. It was an inpatient program to the end where I could spend all this time with them and help them again to come out of this program and have a good quality of life. So with that said, we hope that we can hopefully answer some questions and give some insights into how you can continue to live a full and productive life, even though you may have a vision impairment.
Oh, thank you so very much. And as I mentioned earlier, this town hall is sponsored by our not-for-profit foundation, Healthy Living with a Vision Foundation. And we actually have a couple of our board members that just got on. Dr. James Thompson, who just got on, is our medical director. And as I said, he has a initiative that he has set up called, it's a 30-day Kickstart Challenge. We won't get into that, but he's really taken a great lead in terms of helping people live better, fuller life through nutrition, which can help the eyes, and we talk about that. And then Al Devaney, who's also on the line, is our board member, also very involved and engaged in the business community. And then I think this might be Angela Wheeler, Dr. Angela Wheeler, who's also another physician on our board of directors. So if anyone wants to check us out, healthylivingwithavision.org is our website where they can donate. And then we're going to move back to our program. Always give us a little shameless plug. Thank you, Al. And then we're going to move on to Dr. McIntosh. And if you can unmute so that you can tell us about what's going on in low vision at Nova Southwestern, what's new, what's innovative, and please share that with us so that we can all learn.
Good evening, everyone. I should say good night, everyone. Thank you, Dr. Johnson, for inviting me on this call. I apologize for break up a little bit. Please let me know ahead of time. I am the Chief of the Low Vision Service at Nova Southeastern University in Fort Lauderdale, and I work with individuals who have a visual impairment on a daily basis. And I think it's beautiful that Dr. Johnson kind of mentioned that many eye care providers out there actually under-refer. There are many patients out there who need to be seen, in my opinion, a little bit sooner in our clinics to be able to maximize the vision that they have. Low vision, which as I said, Dr. Puma mentioned, we're kind of moving away from that type of a terminology, but vision rehabilitation really is an opportunity to help individuals who have a visual impairment or difficulty seeing to function in their everyday life, to maximize, because your life doesn't stop when you get a certain diagnosis. Your life still goes on, and you still want to be able to live that life as best as you can. And that's where vision rehabilitation really comes in. There are different tools and technology that are available to help you to utilize and maximize the vision that you have. And technology is changing by the day, to say the least. Every day there's a new app that comes that's actually available, some of them for free, that really do help individuals who have a visual impairment. Certain apps, such as the Scene AI app, which is available on iPhone products or Apple products, that actual app really helps patients to either use a magnification that's available, or they can even use it to identify colors or money. There are other apps like Be My Eyes, which allow individuals who want to be able to assist other individuals who have a visual impairment. And this particular app utilizes the phone camera and allows someone who is not in the same vicinity as that individual to utilize their camera to help them to find something. So it really allows a buildup of a community to help someone who's visually impaired. Some of the current software that's available, such as Windows, they actually have built-in accessibility features. So there's many things that are already available in patients' lives that can be utilized that people don't know about. It doesn't need anything specific, but just maximizing or utilizing what's already available at the tip of our fingers, to say the least. And I'm really an advocate for early referral for patients, because vision loss, unfortunately, it's a journey, and it's learning how to cope with the new type of vision that you have and how to live with that vision. And many times it's easy to go through that process, or the process becomes a little bit easier when your doctor tells you that, you know what, yes, you are having difficulty seeing. You're no longer that 20/20, but there are things that are available to help you. And I think us as eye care providers really need to get better at having that discussion with our patients to really let them know that, yes, life goes on and we will be able to help you the best that we can through vision rehabilitation to make the best out of everything, to use the vision that you have. And it's not only optometrists, ophthalmologists, unfortunately, are also guilty of this. So I'm hoping that through this awareness and different projects like this, we're able to not only increase the awareness with providers and kind of remind them what they learned in optometry school, but also with patients themselves so they can be their own advocates when they go to their doctor. Like, I've heard about this. Is this something you think would be beneficial for me? Or do you have any of those resources or know of those resources for me? So I think this is a wonderful program or foundation that you've set up. And I'm looking forward to answering any questions that come up from this discussion.
Well, thank you very much, Dr. McIntosh. So you know what, when I tap into people, you stuck with me. So, or I'm stuck to you. So we will definitely continue to utilize you as a resource. And I want to point out, Dr. Primo is not the only classmate of mine that's online right now. And yes, I'm calling you out, Joanne, Dr. Joanne Caruso, who's also online. She's on faculty at the New England College of Optometry. And she joins us again. So thank you very much for joining. And I know she is a big low vision advocate. Do you have anything you'd like to add?
No, I think, it is correct. We probably don't do under refer to low vision. I'm at the college part-time, and then part-time I have a practice, and I'm lucky because my practice is in the same town as the Perkins School for the Blind, and next town over from the Carroll Center for the Blind. But I think, I probably, like everyone else, don't refer as much as I probably could to have them, patients get those services.
All right. Well, thank you. Like I said, I'm a living testimony of being an under referral. But Dr. Parise, even though she's under the weather, she sent some information here about Hadley School for the Blind that's in Winnetka, Illinois. And she mentioned that they have a lot of resources, and they actually can do remote Braille training for people all over the world. So anyone that's interested in learning Braille, they can do it remotely all over the world. So one thing that came out of pandemic is that things we can do with Zoom and just other different technologies, that we can reach so many people, so many more people, and so many households. Hopefully everyone will tune in and stay on our website to check out when our next we're going to change it to Vision Rehabilitation Town Hall meeting. So I appreciate you all correcting me on the verbiage for that. Because Janet Lebrecht herself is legally blind, living with retinitis pigmentosa. In other words, a progressive disease. So she was sighted. She had normal eyesight as a child, and that is a genetic disease that robs you of your eyesight as you get older. But she is a real energy fireball. Just nothing stops her. One of our past sessions, we talked about guide dogs, and I had no idea that guide dogs usually are free. There's funding out there, so people that qualify for a guide dog can get one, and it's not a financial situation, but the only caveat, you have to be able to take care of a dog. In other words, buy dog food, take them to the vet, and things of that nature. And sometimes you can receive supplemental support for those sort of things. So I've learned a whole lot. And Dr. Primo, is there anything else you want to add in terms of, we've talked about pediatric children that have that need vision rehabilitation, and again, so many times we see patients and we just feel we can't do much of them. And I'm thinking of patients in my brain right now that after they've had their surgical procedures and they're legally impaired because of diabetes, that I'm going to get them to a low vision specialist when the specialist is finished with their treatments. Dr. Primo?
Yeah, well, I was just going to add what brought to mind is resources. And so there are resources out there, even if they're not physically available in where you live. If you're in a rural area or you're just not in a location where there might be somebody like myself or Dr. McIntosh around. Hadley website is phenomenal. There's so many things on there, from support groups to training on kitchen activities, all sorts of things from soup to nuts. And so I would encourage everyone to go to that website. It's very, very well put together. It was just redone. Again, there are lots of virtual things so that you don't have to be physically present. The other good one is the National Eye Institute, has a wonderful website and resources. I mean, I think that the key and the common theme would be finding resources and support. So someone who is visually impaired, you're not alone. And so your family is there for you. And certainly there are other people in their community, but we also need to educate a person's family and the community about visual impairment. And so the better off that one can go to websites or go to whatever mechanism you might go to get resources and information. There is a lot out there. And so I'd encourage everybody to do that. Especially if you have a child with vision impairment, clearly that can be a very stressful thing. I mean, sometimes when it's a condition, the parent may also have it. And so they may be a little bit more used to dealing with it and visual impairment. But, a lot of these diseases are what we call recessive traits. And so parents may not have it, or maybe somewhere in their family, but they don't know who has had it. And then all of a sudden the child ends up with something. You're like, where the heck did this come from? And they think they did something wrong, and they didn't. Was a very recessive gene. Stargardt's is a perfect example of that, which is juvenile macular degeneration. And so the key is, again, to find support, whether it's a virtual, social media, online, or physically finding information. So I would encourage all doctors and their staff, not just the doctors, but it's also staff and other medical providers. We're doing a program with NEI to help and prevent blindness, to help educate primary care people, because primary care providers also need to understand about vision and vision impairment because it affects their treatments. There's research that says, people who are blind or visually impaired have a longer hospital stay and all sorts of things. And so because of their inability to be able to manage the disease with their loss of sight. And so more at risk for slips and falls and fractures in the elderly. I mean, they're just the whole, I could spend an hour talking about it. So the key is to educate everyone, from family members to the community to medical providers to eye doctors, to understand, to be able to ask patients, are you having a problem with your vision? And then to find the resources to help with that.
No, thank you very much. And again, you brought to mind access. So again, we have, let's be real world, where you may have a senior that is not as technology savvy. So you have a senior that does not operate and know anything about an iPhone, and think about how can we reach them. So they really need to have a family advocate. The other thing that, again, our foundation is getting involved with is mental health. So understand this, that people that might be having a newly diagnosed vision impairment where they have lost their eyesight and they're used to having it, there's a high level of depression. So mental health, so we need to make those mental health referrals also. And again, these are areas where optometry can really shine, because we talk to our patients and we should always keep those things in mind. So think about the people that need help, not only mental health, but help in terms of resources and things of that nature. So we all got to take care of our seniors. So again, they might not have the technology, but we have to talk about the other resources and all that they might, that we can offer to them. And again, we have a home health agency too, and maybe we need to train our people more. So those are just thoughts. Any other thoughts, Dr. McIntosh, on low vision, or Dr. Caruso? And then we're about halfway through, and then we're going to move over to another part of our program.
I think I'd just like to piggyback on the mental health aspect, because I think sometimes optometrists and ophthalmologists forget that it does have a mental health component. And honestly, patients might not feel comfortable just opening up. So it might be nice to have a questionnaire, like the patient health questionnaire, where you ask a few questions just to open up that conversation, so you know that it's okay, or they'll know that it's okay to actually discuss how they're feeling with you. And you can normalize how they're feeling and discuss with them the resources to address how they're feeling, whether it's counseling or group counseling or group sessions. I think that's a great opportunity for them.
Yeah, that's a great point. I'll just say the mental health and the depression screening, and this gets back to sort of educating primary care providers, not just eye doctors, but primary care providers, from nurse practitioners to PAs, to physicians, about the effects of vision impairment, and to let them understand absolutely that there is a lot of depression and mental health issues that go along with it. So basically everybody needs to get on board. And so whatever your specialty is, or whatever your line of work, to understand all the ramifications of one losing sight. So I think that's very important. Let's see, so Dr. Johnson may be tied up for just a minute. So I think we'll move over to Dr. Elder and to talk a little bit more. She is, again, Dean of, she'll introduce herself, but she is Dean at the College of Optometry, and we'll move over to her.
Hi, thank you, Dr. Primo. So I actually, while you guys were talking, I went and found the little bio that I submitted for something else this week. So I'm just going to read that really quickly to introduce myself. So Dr. Keisha Elder is a clinical professor and dean at the University of Missouri, St. Louis College of Optometry. She was born in Columbia, South Carolina, and graduated from Clemson University with a Bachelor of Science in Science Teaching Mathematics. She received her Doctor of Optometry, Master of Science in Vision Science, and Master of Science in Instructional Design and Development degrees from the University of Alabama at Birmingham. Dr. Elder has lectured nationally in the areas of health disparities, diversity, equity, and inclusion, contact lenses, dry eye, and clinical procedures. She serves as the chair of the nominating committee of the American Academy of Optometry, associate editor for optometric education, and board member of the National Optometric Foundation. Additionally, Dr. Elder is active in her local community as a member of the St. Louis Optometric Society, the Missouri Optometric Association, and the Gamma Omega chapter of Alpha Kappa Alpha Sorority Incorporated. She is also a veteran of the United States Navy with duty stations at the Naval Health Clinic, Annapolis, and the Pentagon De Lorenzo Tri-Care Health Clinic. So that is me, and a little snippet into my professional career. And so I'm just thankful to Dr. Johnson for inviting me to speak with you this evening. So what would you like me to start with, Dr. Johnson?
All right, well, thank you very much, Dr. Elder. I'm sorry I got a little bit distracted. We talk about home and elder care. I'm at my mom's house, so got to take care of mom first, but that's okay. I want you to talk a little bit about, we're so proud of you, and I'm sure you've heard so many accolades in terms of your accomplishments in terms of being there. But what we'd like to hear from you is, again, part of our thing, we want to highlight African-American faculty at schools of optometry around the country. And so are there others that look like you at UMSL, and any of the others that might be on the line? Dr. McIntosh is one from Nova Southwestern. Are there any others there? And are we progressing in that area? And what are some of the challenges to African-American faculty?
So when talking about African-American faculty specifically at UMSL, we have 3 full-time faculty that African-American, including myself. There is Dr. Angel Novel Simmons, Dr. Brittany Wright, and me. So actually UMSL's percentage or number of African-American faculty is probably on the higher end of African-American faculty at optometry schools. As far as the current national average, only about 4% of faculty are, I think around 4% of students are African-American. I think the percentage of faculty members that is African-American is a little bit lower. It is really interesting because, and that makes sense, because you have to get African American from the optometry pool, if we only have 4% of optometry students who are African American, it stands to reason that a small percentage of those students are going to go into academia. So the amount of minority faculty members, underrepresented minorities, and African Americans in particular is very limited. And there are certainly schools in the nation that do not have any African American faculty at all.
Wow. Well, that's a problem and argument we've been saying for quite a long time. Having been a former board member of the National Optometric Association, and also a newer organization called Black Eye Care Perspectives. And they have a 13% challenge where they put it out there for not only for schools, but for industry companies to make a commitment to have as a goal 13% African-American representation. And I'm proud to say that my own alumnus of New England College of Optometry was the first program to accept that challenge and move in that direction. So Dr. Purcell, who's not on the line, he was on our previous, was the first president to take that on. But now we have to figure out how do we do so, and how do we do that step by step in detail. And that to me means starting at the elementary and middle school level and on up from there. But with that being said, I also wanted Dr. Elder to kind of chime in on the growth and how the optometry education has really developed in terms of increasing in our scopes of practice. We know on a higher level, there's some political battles, but what's going on with optometry school education? What direction is it going? What new things are you teaching the students? What are the challenges in terms of the real world that you're trying to make students have a good transition from academia as a student to practice? And there are so many various modes of practice for optometrists. So can you speak to that in the education and how it's evolving?
Yes, I think the trajectory of optometric education is excellent. The scope of practices in the states differ based on the state legislation. However, the optometry schools consistently do teach the students up to the highest standard of care. So when a student graduates, I could speak specifically about the UMSL College of Optometry, they are able to go and get licensed in any state. So I do think as faculty members, it is our responsibility to make sure that we are teaching our students the latest, greatest as far as patient care, technology, and things of that nature, because we do want to make sure that when our students graduate, they're able to practice at the highest scope. I do think the trend toward scope expansion is really going across the United States, so I do hope that there will be a point where every state has a really great scope of practice, but I am confident in saying that each of our schools teaches our students to be able to teach to the highest scope, to practice at the highest scope, excuse me. Right. And I don't remember the other question.
Okay, well, I want to talk a little bit about how in the real world, we work very well and closely with optometry and ophthalmology. So some people don't know the difference. And again, this is also directed towards the consumer. So we have many consumers that say they want to go to an ophthalmologist, or because they may have a certain condition or may not, they just feel that their level of training is different. Where I explain to patients that we're pretty much your primary care physician for the eyes. Now, and that ophthalmologists are generally surgical specialists. So can you get into the difference in the training between an ophthalmologist and optometrist?
Absolutely. When I kind of talk about the difference between the eyes, I talk about the 3 O's. We have the optician, you have the optometrist, and you have the ophthalmologist. When you think about the optician, that is the person who actually can make your glasses. They can order contact lenses for you, but those are ordered or made based on prescription from licensed eye care providers. Then you have your ophthalmologist or your eye surgeons. Ophthalmologists complete undergraduate school. They complete 4 years of medical school, then they do their internship, and then their ophthalmology specialty. And then in many cases, depending on what they want to do, they may do a subspecialty. So an ophthalmologist, after they finish medical school, typically have at least 4 years of training specifically in eye care and eye surgery. And then you have what I think is the best of all three in optometry, which is what we are. Optometrists complete their 4-year undergraduate degree. Then they complete 4 years of optometry school. And when we graduate our professional program, we have an OD degree, which is a Doctor of Optometry degree. Once we graduate, similar to dentists, we are able to go out and practice full scope optometry. However, we do have the opportunity, if that is what we want, to do a residency to specialize in an area. And with our residencies are typically 1 year in areas such as cornea contact lens, low vision or vision rehab, vision rehab, ocular disease, things of that nature. So optometrists can, once they complete optometry school, we have the option to go and do a 1-year residency if we like. I think one of the great things about optometry, and why we are so good at what we do, is that we spend all that time, we learn a lot about the body, the systemic diseases, and how these things manifest in the eye. And many people don't really know that optometrists, we can treat eye infections, of course. We can treat like a herpes simplex eye infection. We can treat styes. We can manage people and treat people who have glaucoma. But also we can look in your eyes when we dilate them and put the drops in. We can see your blood vessels. So in many cases, optometrists are the doctors who diagnose the patient with high blood pressure, with diabetes. We're able to tell in some cases if a patient has tumors. There's a lot of things that we can actually tell about a patient by dilating their eyes. So I think people sometimes pigeonhole us into think that we only do glasses and contacts. Glasses and contacts are wonderful. Glasses and contacts are important because they really impact people's quality of life, but optometry is a lot more than that.
Yeah, thank you for that, Dr. Elder. I think that clarifies something. And a lot of that is just public perception, because what most people don't realize is that many optometrists train with ophthalmology residents. Where I trained, my internship was at Brooke Army Medical Center, and we were training side-by-side ophthalmology residents. Shorter period of time, but again, the ophthalmology residents are training for surgeries. They're learning surgeries and things of that nature. So when it comes to diagnosis, in terms of observing, looking at different tests and imaging that we do in the back of the eyes, for instance, there's a study in terms of macular degeneration. Optometrists scored pretty equal to ophthalmologists. So again, that's basically how I term the definition. And thank you for that, Dr. Elder. Now, I'm going to stay on you, Dr. Elder, because you're the superstar in terms of optometric education. You're saying expansion of scope. So again, some people may hear where optometrists are trying to do surgery and take ophthalmology's job. Well, one of the things that optometrists, we are more accessible. You might find it a lot easier to get into your optometrist in the evening and on the weekend than in ophthalmology practice. I know during COVID, we were considered an essential business, and we were trying real hard to keep people from going into the emergency rooms because of eye issues, eye emergencies, because the emergency rooms are pretty dangerous places then, and they're not the safest places now. So in terms of eye issues, the things that you're teaching your students and that I've learned, and Dr. Primo, Dr. Caruso has learned, and Dr. McIntosh has learned, that we can treat so many things that keep people out of the emergency rooms where we don't have to cut into the eye and do various things like that.
Yes. So, sorry. You weren't done.
Go ahead.
Yes, that is correct. And I think public health is people are healthiest, and we have the greatest positive impact on public health when optometrists and ophthalmologists work together. So typically, as I said before, optometry students are trained to treat patients up to the highest scope of care, meaning the state law that allows optometrists to do the most wherever that state is. That's how we train our students. When we talk about scope expansion, we're talking about, just as what Dr. Johnson said, we are trying to make sure that patients have access to good quality eye care in the most accessible way. We are not trying to have the permission or the license to do things that we aren't trained to do. And even when you talk about access to care, sometimes people are in remote areas and they actually don't physically have an ophthalmologist near them, but they may have an optometrist right there. But even in the city, as Dr. Johnson said, you may have ophthalmologists everywhere, but it may take 2 months to get in to see that MD, the ophthalmologist, where you may be able to get into an optometrist's office within a couple of weeks. And some of the things that many optometrists are able to do, things like the YAG capsulotomy, that's a laser procedure, not the refractive surgery laser procedure, but a procedure to kind of clear up the back of your lens after cataract surgery. Those things are relatively non-invasive, have a really good recovery rate, a very straightforward procedure. So optometrists are not trying to do invasive things that we aren't trained to do. We're just trying to take care of patients the way that we're trained in order to keep our patients as healthy as possible.
Thank you very much, Dr. Elder. One thing, and I can pontificate on this quite a bit, because I think another thing that the public's kind of misconception is that there's a lot of corporate entities that are in eye care, which is fine, that allow patients to get in and get their eyes checked, get glasses inexpensively and whatever, which is great. But the public perception is that that's all that we do, glasses and contact lenses, when there's so much more. And we find people with diabetes and some of the company business models may not be managing those eye conditions. And so they, a lot of times, will have to refer out to an optometrist or an ophthalmologist to that follow-up care. Another bit of confusion that a lot of people in the public have, that we try to educate every day, we deal with two different types of insurance plans. One is your vision plan and one is your medical plan. And in a lot of cases, those vision plans will not cover medically related eye care. So say you have an eye infection or an allergy, or you have diabetes you need to be monitored for changes in the back wall of the eyeball. That's not covered by your vision plan. Your vision plan basically covers coming in, evaluating a health screening, and evaluating if you need a change or update in your glasses or contact lenses. And then how we explain to patients with the medical insurance covers anything else related medically with the eye. It could be something as simple as dry eye, irritated eye, tearing. So those are the things that Dr. Elder, Dr. McIntosh, Dr. Primo, in addition to vision rehabilitation, those patients have a lot of those issues. And that might not contribute a lot to their vision impairment, but your quality of life. Who wants to walk around with eyes that are tearing all the time, or red and discharge, or styes on their eyelids? So those are the things that we as optometrists do every day. Dr. Caruso, Dr. McIntosh, Dr. Primo, you all have anything to add on that? Sort of what I mean is the kind of conditions that you all kind of deal with every day as an optometrist that maybe most people don't think about.
I mean, I think, Dr. Elder has said it all. We are the primary care, and you all said it all. We are the primary care eye person. There are more of us. There are 4 times as many optometrists as there are ophthalmologists. And so the majority of the public needs primary eye care. It's kind of like the difference between a regular dentist where you go to get your hygiene a couple times a year, and the orthodontist or endodontist or something like that. If people need that sort of thing, they're there, but you would need your regular, bread and butter dentist and hygienist to be able to care for you. And so I think the key is, whether you have a vision impairment or you have a problem, we want to make sure that everybody knows they have to get, depending upon their age and other risk factors, really an annual or comprehensive, eye exam on a regular basis, whatever that may mean for a particular person. Clearly for diabetics, that needs to be once a year. And for others, it could be every couple of years. Again, it depends on your age and your risk factors. But I think once we can get people thinking more of, regular, continuous, not episodic, not the emergency room, not an eye screening or something like that, but continuous primary eye care, that's what's going to help lessen the burden of the potential for vision impairment from disorders. So if we can catch glaucoma early, if we can catch things going wrong in the back of the eye from diabetes or high blood pressure, obviously that's going to be a medical thing that we can help as well. But we want to be able to prevent whatever is going to happen perhaps in the future. And so just getting people used to getting regular eye exams, I think, is very important.
Yeah, thank you. Thank you very much for that. Regular eye exam. So I want to circle back to vision impairment again, because that is the theme of these town hall meetings. One of the things we'll probably be adding, which is another subspecialty in eye care, is myopia management. So I have a new associate that's her passion. And so she has a very, very high, thick eyeglass prescription. And there are various ways we can handle that now with tools we didn't have before. Special contact lenses, or also when children are at a young age, we can slow that progression in nearsightedness down, because as we know in the profession, but the general public, I don't think really knows real well, that when you have your extremely nearsightedness or a thick prescription, that puts you at greater risk for vision impairment and needing vision rehabilitation, from macular degeneration to glaucoma to retinal detachment. So if we can prevent that on the front end, 10, 20, 30 years down the road, our children will be much better off. And that myopia is an epidemic now, especially with COVID and kids being on tablets and their phone and all like that. So we're excited about adding that to our repertoire. But circling back to vision rehabilitation, and I want to talk about, people say, well, I have an aunt, I have a grandparent, or my daughter. How can people, if they don't have their own private practice or independent optometrist, or they were just told they can't do anything better with their glasses, just the consumers just listening to this, how can they find out or find a vision rehabilitation specialist in their area?
Yeah, Dr. McIntosh, do you want to add to that?
Sure. I'm still here. I've recently learned about kind of a tool that not only patients can use, but providers can also use to find local low vision providers. And I think it's actually like a national movement. I'm not sure if Dr. Primo is aware of it. I think it's through, I can't remember what it's through. If I find it, Dr. Johnson, I'll give you the info so you can share the information with those on the panel. But basically, it's a registry of low vision providers throughout the US. And through that registry, individuals can find providers or local providers. So when I get a chance and I'm not driving, I'll provide that info to you so you can share with everyone that's on the call.
Great. So I think you're referring to the Low Vision Council. Is that what you're referring? Yeah. So that's something that's just come out, spearheaded by Dr. Henry Green, who's out of North Carolina. And basically he covered the entire United States and talked to people and networked to try to get this database put together. So it's the Low Vision Council, where you can go in and find agencies, doctors, what have you, that specialize in vision rehab. So if somebody is not savvy with a computer or phone or what have you, if they can have a family member go into this and find what's locally. One of the challenges is that there is a dearth of vision rehab providers, meaning doctors across the country. It's been that way for decades, and we're hoping the schools and colleges can encourage their students and their trainees to go into this area. As the demographics change and people get older, we're going to find that there's obviously going to be a higher level of vision impairment and the burden of vision loss. So we need to start by getting more doctors into the field and into the specialty. But as I mentioned earlier, there are certainly lots of resources. And, unfortunately, we're in a digital society, right? And so at some point, you've got to do your research. We used to be able to go to the library and do all research. I mean, everything is really digitized these days. So if not for the patient, for the other family member to go and look, and that, I think the Low Vision Council, that's great. You mentioned that, Sammy. That's a great resource to begin with.
No, thank you very much. And those of you that are in Illinois, Dr. Tracy Williams, he has a executive director of Spectrios Institute, which is his low vision organization, Spectrios, and they're also a not-for-profit. There's Lurie Children's Hospital, which has outpatient center. but it's going to be about advocates. So and again, I'd encourage anyone on this line, as you listen, to donate, go to healthylivingwithavision.org, and that will allow us, if you want to specify your donation to be for vision rehabilitation, and we can try to help people that don't have the resources or medical resources, where at least maybe somebody can go out and train that individual face to face, because I think that's probably the most effective. Transportation can be an issue. So if it's something as simple as providing transportation to a vision rehabilitation clinic, that would be great. And that's why I wish Janet was on the line, but we'll catch her next time, because she was a commissioner in the state of Massachusetts in vision rehabilitation and services. And underneath the U.S. Department of Education, she also served in that role. So we should talk to our politicians, and we should talk to our local representatives in terms of funding, because that's a huge need. And if we can keep people as independent as possible, that's going to lower our costs. And that's what's hard to get our government officials to understand. You put the money up front, it's going to save you so much more on the back end. But again, I pontificate again. I have Dr. Thompson on the line too, one of our board members, if he's able to unmute and tell us, as a primary care physician, he's board certified in internal medicine as well as immunology and allergy. Maybe if he has any experiences with any of his patients that might be vision impaired, and from his perspective. I know he's listening in, but he might not be able to get to the phone. There he is.
Yep. Yeah, I'm a little fumble-fingered with these iPhones on Zoom. Sorry. Yeah, I've been listening the whole time. Yeah, I'm an allergist in the Chicago South suburbs, been in practice for 33 years, internal medicine based. But I see all ages as an allergist. And what I see mostly in the ocular area, of course, is during the spring, summer, and fall, people that have, ocular allergic-based conjunctivitis. And a number of people, though, I see have comorbid problems. A number of patients have diabetes. And so I remain very conscientious of the fact that they need to have good eye care. I know it seems like in primary doctors examining the back of the eye or the retina with the ophthalmoscope is a lost art, because I know I don't think I've had my eye checked by my eye doctor ever. And I think we kind of left that up to people that are in optometry and the ophthalmologists. But certainly, you don't find out, you don't realize the value often of your eyes and your vision until you start to lose it. And so I do think a role that even specialists like myself see, that specialists like myself should adopt the fact that we need to make sure people have their vision checked and preempt, some of these diseases that can show up so readily. So thank you.
Thank you very much. When I talk about our foundation, I'm really into collaboration. And I think we as optometrists, we all stay in our little tunnels, just looking at the eyes, but we really need to do a better job talking with our colleagues in other subspecialties. And I think those of you that are in vision rehabilitation, just because your patient base probably have a lot higher level of those comorbidities, I don't want to say forces you, but you're able to engage more with their other specialists. And so that's a good thing, because again, we're talking about patient-centered care. So we need to engage their other medical professionals, and they might not even be their physician. They might be a nurse practitioner, physician assistant. They could be a CNA that stops by and gives them their medication, their podiatrist. Podiatry referrals is something else that we probably under-refer for people living with diabetes. So we're rounding the corner to 7:30 Central Time and 8:30 Eastern. And I'm going to ask for closing remarks from Dr. McIntosh.
Well, as I said, I think this is really an amazing thing that you've actually been able to put towards like a town hall meeting and have this particular foundation that you have. I think is a great step towards increasing awareness for individuals within the community, but also for providers, whether eye care providers or allergists or any type of medical providers, because all of our goal is to improve the quality of life and the life of our patients in general. And I think it's nice to have a setting just like this. And I hope that through this particular call that we were all able to share information and maybe pique others' interest in what else is out there with regards to resources, or how can I practice differently, or how can I engage differently with my doctor to make them, force them to maybe consider this if they're not considering this. So thank you for the opportunity. And if anyone has any questions they can share with Dr. Johnson, I'll be happy to respond to them. And thank you once again.
Sure. Thank you, Dr. McIntosh. What we'll do, if you check our website periodically, we'll have a link to some resources, the low vision resource, and because our website is going to be a plethora of information. And so just check our website, healthylivingwithavision.org. Periodically, within the next week, we should have some information up there, some references we talked about. Dr. Caruso, I got to call my other classmate out. Come on. Got any closing remarks?
No, it was great. Thank you. Very informative. And I forgot to say our other classmate, Lisa Kralian, was going to be on, but she couldn't. So hopefully next time, she said.
Okay.
And thank you so much.
You're welcome. We are doing these about every 3 to 4 months. So we're probably looking at May, but I'll let everybody know the exact date when it's nailed down. And Dr. Primo, any closing remarks?
Yeah, Dr. McIntosh had said it beautifully, but take care of your eyes. If you do unfortunately end up with a visual impairment, you are not alone, that there are resources out there to help, and know that it is truly a journey, but the end of the journey is quality of life, and so we are there to help you.
Thank you very much. And then last but not least, our very special guest, the first African-American woman Dean of Students at a College of Optometry in the United States. Dr. Keisha Elder, we're going to let you finish up. And what say you?
Okay, so speaking as a dean, I think one of the biggest pushes throughout the profession of optometry as it relates to the schools and colleges of optometry is trying to increase the quantity, quality, and diversity of the applicant pool. Because we increase those things in the applicant pool, we get more good, qualified, diverse students in and can graduate more optometrists. So I need each of you to help us by talking to your friends, your neighbors, anyone that you know, any high-performing, inquisitive, people-loving, science-loving young folk. Talk about optometry, make sure they consider it, because in many cases, the high performing, especially minorities, get pushed to medicine and dentistry, but people don't think about optometry. So if you have a student who's interested in doing something fantastic as far as career-wise, explain optometry. Have them reach out to one of us, and we can hopefully pull them into the fold of our profession. And thank you for having me.
No, thank you for joining in, and hopefully you will come on board with our future broadcasts. So thank you. And I do have to put in another shameless plug for our board member, Dr. Allison Devaney, because this brother is out there in the community. He has mentored so many people. So he's going to help me identify some young men, African-American men, that I think we can probably put in this pipeline. So I'm just pulling your, just pulling your chain, Mr. Devaney. This is where we're going. And part of our initiative also is recruiting. So, and again, finally, healthylivingwithavision.org. Our page is being revamped as we speak, updated. So it's going to be a plethora of information and things that we talk about here. So at this time, we're going to thank everyone for being on the panel. And hopefully this will be just the beginning, another stage of going forward and higher. And as I always like to say, be well, see well, be blessed. Thank you, everyone.